And Aaron, just tell me when you want me to start.
Will do. Thanks everyone for their patience while we're letting people into the room. We'll be starting momentarily.
Can you hear me okay, Aaron?
Yes, perfect.
Great.
Thanks everyone for your patience. We're just going to give it one more minute while people continue to file into the room. I think we can start now, Greg.
Great. Thank you. Will do. Good afternoon, everyone, and welcome to this webinar entitled The Role of the Aging and Disability Networks in CMS's Guide Model for Dementia Care. This is Greg Link. I'm the Director of the Office of Supportive and Caregiver Services here at the Administration for Community Living. During this webinar, ACL and our colleagues at the U.S. Aging Business Institute are going to discuss opportunities for our networks to engage in the Centers for Medicare and Medicaid Services new demonstration program at the Innovation Center on new dementia care initiative known as Guiding an Improved Dementia Experience, or GUIDE model. GUIDE focuses on dementia care management with the intent of supporting people living with dementia and their family caregivers in their homes and communities. We will explore the roles that the Aging and Disability Network organizations can take in developing and delivering sustainable contracted services under this model. The Aging and Disability Networks are really well positioned to participate in and/or partner with this initiative as providers of a range of different home and community-based services required by the CMS Innovation Center for this particular initiative. This webinar is going to provide some important details on how to become meaningfully involved in this initiative, and we're going to conclude the session with a question and answer period. As you may be aware, supporting individuals and their families to help them remain in their homes and communities through a variety of efforts and focus areas is definitely a priority of the Administration for Community Living and for U.S. Aging. Support for families and caregivers has been at the front and center of the Biden-Harris administration and is a priority also for HHS's Secretary Xavier Becerra, who together have given us the term caregiving infrastructure and has called out the needs of family caregivers in multiple ways, including in an executive order early in 2023 that directed numerous federal agencies to take actions to improve the programs and supports that provide family caregivers and opportunities to have adequate and high quality direct support services. Over the past couple of years, ACL has been directly engaged in advancing the administration's commitment to enhancing supports for family caregivers, as well as strengthening the direct care workforce. We at ACL believe that the new GUIDE model is one of those key opportunities for the Aging and Disability Networks to fully engage and to be partners and/or participants in full with these new models as they get underway. The speakers that you're going to be hearing from today are going to share a lot of details with you. First will be Aaron Long, an Aging Services and Program Specialist in ACL's Office of Supportive and Caregiver Services. Aaron oversees ACL's dementia portfolio and has worked very closely with our colleagues at CMS to refine and shape the GUIDE model as it was being developed. Aaron will provide an overview of ACL's work in the dementia space through our administration of the Alzheimer's Disease Program Initiative and the opportunities that GUIDE creates for our networks. Aaron will also discuss the purpose and intent of the GUIDE model and what it means to be a participant versus a partner in this network. Our second speaker is Marisa Scalafoli, who is the director of the Aging and Disability Institute at US Aging. Marisa will focus on the business opportunity the guide model creates for our networks and share with you resources and information that are available should you decide to take an active role in the implementation of the guide model in your community. So without further ado, I'm going to turn the webinar over to Erin, who will share some important housekeeping information and get underway with the details. Erin?
Thanks, Greg. First off, housekeeping. If you have questions, you'll see that at the bottom of the screen or in your screen, you should have a Q&A button, so you can put your questions in there, and we will, if they're answerable in the chat, we will do that. And then otherwise, we're going to have a Q&A session at the end of the webinar. We are recording the webinar, and we will be posting the slides and the recording on the National Alzheimer's and Dementia Resource Center website, which is nadrc.acl.gov. Next slide, please. So Greg already went over the three of us as the presenters, and next slide is just a slide holding for the background, and the next slide is our learning objectives. We just wanted to sort of, Greg just gave us the policy context for the guide model. I'm going to talk a little bit about ACL's existing dementia programming and the aging network. We're going to give you an overview of the participation and partnership and guide, and then Marisa Scalafoli is going to talk about insights into the Aging and Disability Network contracting. Next slide, please. So some people might be wondering why ACL is hosting this webinar, and I'm just going to give you a little background on how it aligns perfectly with ACL's, the Administration on Aging's mission, and then our Alzheimer's Disease Program Initiative. The overall mission of ACL is to advance independence, integration, and inclusion through three key strategies: investing in core HCBS that help keep people in their homes, building partnerships that leverage additional public and private resources, and promoting innovations to ensure continued effective outcomes for the future. Many of you may know that ACL has, through its Alzheimer's Disease Program Initiative, which is an evolution over many years of providing Alzheimer's programming. We started in 1992. We have been funding states since 1992. In 2014, we were able to begin funding communities directly. And you'll see in the description, I imagine most of you have sort of perused the guide RFA, and I just sort of highlighted the words in our strategies and our programming that align with the language that's used and the intent that's documented in the RFA for the CMMI. So we're at ACL's, through our state and community grants, we're filling gaps in services and supports through home and community-based services and targeted training in states, communities, and tribes, and reporting and improving the quality of life of people living with dementia and their caregivers, maximizing health, independence, and well-being. We also, this year, we funded a new innovations and respite program that also aligns with the work that is coming out of CMS, and that is going to further development and testing of innovative community-based dementia-specific respite models, and it's going to include training and technical assistance. The grant was awarded to the Alzheimer's Association, and then the Alzheimer's Association is then going to be fielding mini grants to support respite innovations across the nation for the next 5 years, dependent on funding from the Congress. Next slide, please. So just to follow on, just to sort of show that that connection, again, I've highlighted these buzzwords that are, this is from the CMMI guide, purpose and mission statements, and they're testing a comprehensive package of care coordination and management, caregiver support, education, respite to impact the quality of life. Same words, just, we're all working towards the same end game of getting people, improving the quality of life of people, keeping them in their homes and communities for as long as they like. And so the guide model, and this is language specifically taken from the RFA. It's designed to enhance the quality of care by improving quality of life for people with dementia, reducing burden and strain on caregivers, delaying long-term nursing home stays, and secondarily reducing hospital emergency department and post-acute care utilization. I just want to, the next slide is a map that reflects the ACL's coverage through our Alzheimer's disease program initiative. And you'll see that we've done a lot across the nation. And the important thing here is what we're trying to do here is helping people or organizations see themselves in the CMMI roles. And by what's reflected on this map is a snapshot of where we have coverage, but also the types of organizations that have benefited from ACL's funding. And you'll see that there's a broad range of grantees in the snapshot. And also, very importantly, as it aligns also with the CMMI, is the diverse and underserved populations that are being served through ACL's Alzheimer's disease program initiative. And you'll see there that we are really covering a broad range of diverse populations. And the next slide. Another thing that I wanted to point out to you is the kind of work that's going on at ACL. Everybody, they pointed out in the RFA for CMMI, for the guide program, they identified a number of evidence-based interventions. You'll see that ACL has been funding evidence-based interventions. Actually, we've been doing it since 2008. And some of the interventions that were called out in the RFA are interventions that ACL has funded at the community level and at the state level. And another important thing is the outcomes and the target populations. You see here in the slide the quality of life, the intent to play, the delayed intent to place, improvements in caregiver stress and burden. So I would encourage you, there's a link there that we have some tools on the NADRC website about that gives highlights on the interventions that our grantees have implemented in the past, and you might be able to help inform your decisions as you're choosing, if you're participating in guide and you're going to be doing an evidence-based intervention through the program, we may be able to help you inform your decisions. The next, so that's just sort of the context of what ACL has been doing and how it fits into what CMS is going to be doing. And in the next few minutes, I'm going to talk a little bit about where your organization might fit. A lot at this point in the game, if you're going to be a participant, you probably already know, and you've already started, putting your applications together and getting your partners. So there's next slide, where do you fit in the guide model? Are you a participant or are you a partner? And it's my understanding that the partners, so the applications are due January 30, I think, but it's my understanding that partnerships will be able to be forged. They don't all have to be forged at the beginning, that partnership lists can grow over time. And since it's an 8-year project, then you'll have lots of time to continue to build your partnerships. So just a couple of next slide is a couple of important definitions. So for the CMMI guide program, a caregiver is defined as a relative or an unpaid non-relative who assists the beneficiary, the Medicare beneficiary, with activities of daily living or instrumental activities of daily living. Depending on the beneficiary's need, the assistance may be episodic, daily, or occasional. Another really important definition is the community-based services and supports. Those are defined as services and supports delivered to individuals in their personal home, assisted living, or group home or other community setting to create or maintain their ability to live safely in the community. So just a couple of examples of those community-based services and supports: transport providers, home delivered meals and grocery providers, doing environmental modification programs, in-home care, exercise, and as we all are really acutely aware these days, those socialization activities that really improve the quality of life of older adults and people living with dementia. So next slide, just real quick, everybody's focused on those delivery domains. So there are 9 of them, and I think it's 6 out of the 9 in the application for the participants. They have to be addressing 6 of the 9 delivery domains. If you are a community-based organization that's presently providing supports and services, I imagine that you're looking at these 9 things and you can see yourself in many of these roles already in just the activities that your organization is prepared to engage in. So, making care plans, monitoring supporting people, care coordination, transitions, just coordinating supports and services. A lot of folks these days in dementia care specifically are looking at medication management and reconciliation, and then the very important respite and caregiver education and support. And if you're trying to figure out the caregiver education and support, I really would highly recommend taking a look at ACL's evidence-based intervention list of evidence-based interventions that our grantees have been implementing over the years, and to get some ideas. Next slide, please. So just all of these items are in the RFA from CMS, but there were certain things we just wanted to pull out for you. So I think most people probably know there's the 2 tracks for the guide participants, and those participants are Medicare enrolled providers with established dementia care programs. They must be participating under a Medicare Part B enrolled taxpayer identification number and meet those care delivery domain. So they are that are outlined in the RFA, and as a participant, they may be meeting those requirements by selecting partners to deliver those services. And then they must have a care navigator and a clinician with dementia proficiency. That's for the 8-year track. And then there's that's the established 8-year track. And then the new track is the 7-year, with the first year sort of being able to prepare themselves to be able to establish something. Next slide. So partners, and that's what we're really focused mostly on here, is those are so the participant organizations, they're going to partner with, hopefully by contracts, with provider suppliers and organizations, including both Medicare and non-Medicare enrolled entities, to meet the care delivery requirements. The participants are going to have to maintain a partner organization roster, and so they'll be able to, and it's through that they're going to be that's going to be able to evolve over the 8-year program, building new partners over at any point during the model. And then just some examples of partner organizations are the HCBS, long-term services and support providers, respite service providers, education and training support, those that provide support groups, adult day health. I mean, we can go on, but I think that it's a pretty broad list of supports and services that people can benefit from to improve their quality of life and their ability to maintain their homes in their communities. Next slide, please. So there's a lot of benefits to participating as partners. There's no question about it. It's a great opportunity to enhance your care coordination and care delivery within a geographic area, thereby improving outcomes of people living with dementia and their caregivers. You, as a partner, you'll have access to the learning and be able to advance your existing capabilities and expand your network. And getting compensated for the services that you're providing. So in blue at the bottom of this slide is the language from the RFA about compensating, the partners being compensated, the participants getting their compensation and then sharing the compensation appropriately with their partner organizations that are providing the services. So and that's what Marisa is going to talk about next, is what the partner organizations can expect and the things that they can do to advance their partnerships. And with that, I'm going to turn it to you, Marisa. Thank you.
All right. Well, thank you so much, Erin, and thank you to the Administration for Community Living for inviting us to be part of today's webinar. We are excited about this opportunity that the guide model offers for the Aging and Disability Network. As Greg and Erin both mentioned, my name is Marisa Scalafoli, and I direct the Aging and Disability Business Institute at US Aging. Our mission is really to help build the capacity of community-based organizations, including area agencies on aging, centers for independent living, and other aging and disability community-based organizations, as well as networks of those organizations, to partner and contract with healthcare entities. And we are also thrilled to be the home of the new Center of Excellence to Align Health and Social Care, which will, through funding from the Administration for Community Living. And that center will support community care hubs and the networks that they lead through grants and through technical assistance in the coming months. You see the URL for our website at the bottom of this slide. We invite you to visit our website. I'll talk a little bit about the kinds of resources we have available on later slides, but that is our URL right there, and we will drop it in the chat as well a little bit later on. So here are, just really quickly, we are funded by the John A. Hartford Foundation, the SCAN Foundation, and the Administration for Community Living, as I mentioned, and we partner with national and local organizations to do our work every day at the Business Institute. And that work entails several things. We do training and technical assistance, like we're doing today on today's webinar. We develop resources that are designed to help community-based organizations and networks through their contracting journey. We do information gathering through periodic surveys to gauge the extent to which community-based organizations and healthcare organizations are contracting. And we, in fact, just closed our fifth CBO healthcare contracting survey a few weeks ago, and anticipate having results to share on that our latest results to share on that in the spring. But I'll be sharing our results thus far on my subsequent slides. We also have consulting services that we offer for larger scale projects. And of course, we try to provide thought leadership at the national level on the value that community-based organizations and networks of CBOs bring to integrated care arrangements to efforts like the GUIDE model that really seek to help align health and social care for individuals with complex care needs. So I've mentioned I'd talk a little bit about contracting, the sort of the context and what we know about contracting thus far between community-based organizations, networks, and healthcare entities. So I'm sharing, as I mentioned, we just closed, literally just closed our fifth survey right before the holidays. So I am sharing results from our 2021 survey, as well as trend data. As I mentioned, the survey we just closed is our fifth survey. We've been doing these surveys since 2017, so we do have some trend data to share as we do on the screen. And our partner on our CBO healthcare contracting survey is Scripps Gerontology Center at Miami University. We have worked together on these surveys since their inception. So when we started doing these surveys in 2017, about 38% of responding community-based organizations, aging and disability community-based organizations, I should say, indicated that they had one or more contracts with healthcare entities, including health plans of varying types, whether that's Medicaid health plans or Medicare Advantage plans and so on, accountable care organizations, physician practices, and so forth. By 2021, 44% of responding CBOs indicated that they had one or more contracts, which is a statistically significant difference. So we are thrilled to see that growth of contracting even through the pandemic years that we have all been living through. I've mentioned, you've heard me mention a few times, not only do we target our resources to community-based organizations, but also networks of community-based organizations. And what we've seen over time is increasingly community-based organizations coming together as networks for the purposes of contracting with healthcare entities within their state, particularly for larger scale contracting opportunities that may come through, for example, Medicare Advantage plans or a Medicaid health plan that may be operating either statewide or in different regions of states. And so what we saw was between 2017 and 2021, the proportion of CBOs with contracts that indicated that they had one or more contracts as part of a network of CBOs doubled in that time. So we're seeing really tremendous growth in terms of the development of CBO networks. And ACL has been supporting those efforts both through funding and through technical assistance. And we are a proud partner with ACL as well as other national partners in that work to help develop community care hubs, which are the lead organization, what we call now the lead organizations for these CBO networks and the networks that they lead. So who are the most common healthcare partners for CBOs with contracts? Certainly at the top of the list, and largely because Medicaid is really familiar with the kinds of services that aging and disability CBOs, as well as networks of those organizations offer, those kinds of home and community-based services that Erin mentioned earlier. At the top of the list, we see Medicaid health plans with 41% of contracting CBOs indicating that they had contracts with Medicaid managed care plans within their state. We also see that Veterans Administration medical centers on the list, state Medicaid agencies in states where there isn't currently Medicaid managed care, or at least Medicaid managed long-term services and supports, and commercial or employer-sponsored plans, and hospitals and health systems sort of round out that top 5. And the most common services that they are offering under contract, many of these are going to sound familiar with the kinds of services that are offered under the GUIDE model, and we'll come back to that in a minute. But at the top of the list, assessment and screening for health-related social needs. We're certainly seeing lots of attention being paid to that these days, with new rules from CMS, for example, requiring hospitals to report on screenings for health-related social needs, as well as the proportion of people whom they screen, who screen positive for specific types of needs. Also, in that sort of top 5, and you're seeing, I think, our top 10 or 11 or so services, maybe it's 12, that are being offered under contract by CBOs. But rounding out the top 5 include care management, care coordination, service coordination, with 40% of contracting CBOs indicating that they offer that in one of their contracts, at least one of their contracts. Also assessments for long-term services and supports eligibility, nutrition programs, and home care, such as homemaker, personal assistant, personal care, and so forth. And who are, I included this slide because one of the things that we asked is about the kinds of populations being served under contract by community-based organizations. So you probably see a number that you might expect: individuals at risk for nursing home placement, those at high risk for either for ER use, for hospitalization or readmission. But certainly for the purposes that we're talking about today, you see in the middle of the screen that 27% of CBOs with contracts indicated that they were serving individuals living with dementia under contract. And we also expect that within some of these other categories, such as individuals at risk for nursing home placement, individuals at high risk for hospitalization or hospital readmission, there's probably some overlap in terms of individuals living with dementia being included in some of those categories, even if they weren't a specific target population for a CBO's contract with a healthcare entity. So we did a little bit of a deeper dive in terms of AAA CBOs and the kinds of dementia care services that they were specifically offering under contract, and how those related to the kinds of services that partner organizations under the guide model might deliver. So of AAAs, area agencies on aging with healthcare contracts, in our last survey, 50% of those with contracts indicated that they were conducting screenings or assessments for health-related social needs, or HRSNs. I always get that wrong in the acronym, as they're now called these days. 45% of contracting AAAs were providing care coordination services under contract with a healthcare entity. 27% were offering person-centered planning. 23% were offering caregiver support and training under contract with healthcare entities, and 23% were also providing respite care under contract with healthcare entities. And again, those could be health plans, health systems, et cetera. So I wanted to talk a little bit about the alignment of the program requirements and the intent of those requirements of the guide model with aging and disability network strengths. And the model speaks to, Erin pointed this out earlier, is really trying to target some of the key drivers of what CMS considers to be poor quality dementia care by doing a number of different things. One, developing a standardized approach to dementia care delivery for the participants within the guide model and the interdisciplinary teams that they lead, providing an alternative payment methodology for model participants. And these last 3 that I have highlighted, really target areas where the aging and disability networks are already providing services. And as you saw in my last couple of slides, they already be providing those services under contract with a healthcare entity. So have that experience in terms of billing and so forth, and the kinds of requirements that often exist for contracts with healthcare entities. So those three drivers that CMS identified that aging and disability network organizations they already address with their services include addressing unpaid caregivers needs, and that can include, as Erin mentioned, training and support services, access to a support line, as well as connections to community-based providers for other kinds of home and community-based services that people with dementia and their caregivers might need. Respite services, as well as screening for health-related social needs, as we've talked about. And Erin talked a little bit about sort of the participating providers, as well as sort of a new kind of the new group within the guide model. And I just point this out less for the sort of the specifics of the delivery domains and so forth, but with some of the elements that are included in here that relate to what their relationship might be with partner organizations. So for the participating group, the group that has established dementia care programs, they have to have a currently practicing interdisciplinary need that provides at least 6 of the 9 care delivery domains, which you can find in the request for application. But again, that team aspect, they have to have an established team. One of the other requirements for them is that they provide sort of a listing of what their partner network looks like. Although certainly, as Erin mentioned, they can be adding partners over the course of the, sort of over the life of the demonstration. But for the new participants, they have to develop a roadmap to implement their dementia care program. And that includes establishing that network of partners and developing those program protocols and workflows through which they will, sort of communicate with their partner organization, and through which will sort of map out how services will flow for people with dementia as well as their caregivers. So there's really that emphasis on the kind of the team aspect of care, for interdisciplinary team aspects of providing care for people who are living with dementia. So Erin talked about some of these, so I won't spend a lot of time on it, but really, we are really pleased to see some of these key messages that have appeared, and these are drawn directly from CMS's resource for partner organization. And we're thrilled to see some of this messaging about the need for partner organizations, and most importantly, as far as we're concerned at the Aging and Disability Business Institute, for compensation of partner organizations. That it's not just for clinicians to be referring into the community without compensation. There really is an expectation that partner organizations should be paid through their contracts with guide participants for the services that they are providing that are part of the services specified under the guide model. So you see some of this messaging here on the screen. Guide participants should prioritize potential partner organizations by their presence in the community, their experience with the population, both in terms of their capability, but also in terms of cultural competency. They also need to identify and engage partners who serve under populations that may have a higher incidence of dementia. And they intend for the guide model to help to enable these partner organizations to continue to advance their existing capabilities and expand their network in order to better serve people with dementia and their caregivers. And then it also the guide model is meant to provide an opportunity for partners really to continue to enhance and improve their care coordination and care delivery models within the area that they serve, and with the intent of improving health and quality of life outcomes for people with dementia and their caregivers. So how can you get ready for this opportunity? Because some of you may, we've heard from some of our members who have already been approached by clinicians intending to apply as guide model participants. But some of you may, if you haven't heard from them yet, some of you may in the future hear from from guide participants who may be looking to develop and expand their partner network. So how can you get ready now? First is really to assess your readiness for contracting. Where do you have strengths? Where might you need additional capacity building? And how ready are you to form these contracts and to perform on these contracts with potential guide participants? Assess who your existing champions are. One of the things that we emphasize in our work is really the need for community-based organizations and networks of CBOs to find champions within the healthcare entities who get the value of the kind of social care that they are providing on a daily basis. So you can you need to assess who your existing champions are among, and also who potential guide participant partners might be for your organization within your community. Another way to prepare is by mapping out the services that you and or your network partners offer that align with the guide model, whether it's caregiver training and support, care coordination, or the other kinds of care delivery services that are listed within the request for application. And then finally, developing a value proposition is another key way to prepare for this opportunity for the services that you mapped out, as I just mentioned. And that value proposition can be one that you are presenting to potential guide partners within your community. So just really quickly, I wanted to include some resources for you all as you embark on this contracting journey. And I did want to mention, and I'm not sure where this slide actually went within our list of slides, because it doesn't look like it made it over into this deck. But a couple of sort of lessons learned in terms of what we've learned that works and doesn't work in partnerships in contracting between community-based organizations and healthcare entities. So what we've learned really that works when it comes to this, some of which we've talked about, finding champions who get the value of the kinds of services that you provide. Certainly open and two-way data sharing between, not only should you as a community-based organization be providing data to guide participants who are your partners in this, but they need to be providing data to you in return so that you can do problem solving, that you can troubleshoot where you need to, and that you can continue to build your value proposition for providing dementia care services. Certainly alignment of mission, what you do as a provider of dementia care services with what a potential guide participant might be looking for within the sort of the provision of guide model services. Openness and transparency and a willingness to work together, because certainly as any demonstration rolls out, as any new model rolls out, there are always problems that need to be solved. And your ability to work together and to see each other as partners and not just as sort of contractors and vendors is really important in this relationship, to sort of be able to as I mentioned before, to troubleshoot, to do plan, do, study, act cycles so you can address potential issues that may arise, and to continue for continuous quality improvement when it comes to the services that you provide, so that these services can be as beneficial as possible and run as smoothly as possible for the individuals who are living with dementia and their caregivers. And then finally, workflows. Workflows are a critical part of any kind of contracting between healthcare entities and CBOs. These and in particular, and certainly will be for those of you who are engaged in the guide model, having workflows that work for both for you and for the guide, those who are the guide participants, for the clinicians whom you're working with, are going to be really important in terms of making sure that the individuals with dementia and their caregivers, it's an easy process for them to make their way from the clinician to your partner, to you as partner organizations for the kinds of services that you offer. So those workflows are really important, and they need to work for both of you, because what we've found in healthcare contracting is, while contracts may be signed at the C-suite level, they're carried out at the staff level. So it's really important that the workflows work both for you in your organizations and for the staff engaged in providing these services, as well as your the clinicians who may be your partner through the guide model. So I kind of went through that slide, but here are some resources that can help you within your journey. And as always, we at the Aging and Disability Business Institute stand ready to help aging and disability organizations, community-based organizations, as well as networks of those organizations who may need additional capacity building when it comes to what healthcare contracting looks like and how you can respond effectively with the guide model and other contracting opportunities that may come your way. So with that, I will turn things back over to Erin, and I will advance to the next slide.
Thanks so much, Marisa. This is a great bunch of information that you provided there. It's super important for people to get that insight. So I just wanted to point out a few resources from the U.S. Department of Health and Human Services. There are a bunch of links there about the guide model, some fact sheets that CMS has created, and then also some resources from the Administration for Community Living and the Assistant Secretaries for Planning and Evaluations Office. If you're not familiar with the National Alzheimer's and Dementia Resource Center, we definitely have resources to support identifying services that you could be providing, and also sort of the things you need to consider when you're making those decisions. You know, the cost, the staff time, you know, to all of this is, all of this whole discussion today is about creating things that are sustainable. There's a link there for the National Family Caregiving Advisory Council and the National Strategy to Support Family Caregivers, as well as the National Alzheimer's Project Advisory Committee, or Advisory Council on Research, Care, and Services, the webpage that has all the information about the national plan to address Alzheimer's and recommendations. It's an ongoing committee, advisory committee, and they're constantly coming up with new recommendations. It's a national plan. It's not just for the feds. It's things that states, communities, even individuals can do. So it's worth a look to as you're thinking about the kinds of services that could be supporting people living with dementia and their caregivers. Next slide, please. And I think with this, after this, we have time for some questions. We've had a really robust bunch of questions that have come through our Q&A button, and I'm just gonna try and go through a few of them and see if Marisa and I might be able to answer. There's some that we can't answer just because we don't have the answers to, just because it's not our lane, and it wouldn't be helpful for us to do it. But there are things that we can answer. For instance, so there was one question about, has CMS disclosed how many participating organizations that they're going to accept? And they have, I asked them that question myself, and they said that they don't have a specific number of target applications and encourage as many entities to apply as possible. Marisa, jump in if there's any question in there that jumps out at you. There's a couple questions about where dental care would fit in. I would just say that dental care would fit in as a partner, getting in with a participant. So because it's really who they would be referring people to for services. So if dental care is something that they're going to be referring people to, then they would be included in the list of partners. There's one question here about whether or not a CBO can be I think they mean a participant. And yes, I mean, most people are thinking of it in terms of larger systems, but if you are a Part B biller, you are definitely and can gather the right team together to meet all of the requirements. You are not required to be a health system. You can be an area agency, or as long as you're, or any other kind of community-based organization that has the TIN and is a biller, and then you just collect the partners to make sure you cover all the bases.
Yeah, so we got a question from Stephanie, who asked, who says she's a CBO leader actively working with guide applicants. They're being asked to provide a variety of services, and that they're being asked to make recommendations on how much they want to be paid for their service delivery, based on the per patient, reimbursement guide. Can you please share dollar amount examples? Certainly, while we certainly can't and would not tell you how you should price your services, what the advice that we can offer is certainly to be looking at the codes and the associated prices, or the associated amounts that CMS will be paying for the kinds of services that are prescribed under the guide model. And they have, it's on page 35. So on page 34 of the RFA, they talk about the per beneficiary per month base payment rate that they are paid for beneficiaries that fall in different tiers. And those tiers are described more within the request for application. But they also, on page 35, list the services under the Medicare physician fee schedule that are included as part of the guide model and the dementia care services offered under the guide model. So those HCPCS codes have dollar figures associated with them that you should be able to look up online. So I would advise kind of taking a look at those and thinking about how what it costs you to deliver the kinds of services you're being asked to deliver kind of might fit within the dollar amount sort of allocated for those particular codes, whether it's transitional care management or chronic care management, et cetera. So that'd be my sort of best kind of advice in terms of how you go about thinking about the payment as a partner organization. And then we had one more question, like right underneath it, that I happened to see from Anne, who asked how this overlaps with CalAIM money. So the short answer is this is payment under two different systems. So the CMMI, the guide model, is for Medicare fee for service beneficiaries, and CalAIM is California's, the overhaul that is happening within California's Medicaid program. So these are Medicare dollars, CalAIM is Medicaid dollars. So while there certainly may be Medicare fee for service beneficiaries who are considered to be dually eligible, so have Medicare and Medicaid, there may be some overlap there, but these are two different funding sources in terms of the provision of these services.
So another question that came up was, in conversations with applicants and participants, we've been told that community-based services and supports are not funded through this grant other than caregiver education and respite. Is it correct that if the participant refers an individual to a AAA partner, for example, for a home delivered meal, the meal will not be covered by this grant? Well, it's not really a grant. It's sort of this pilot project, but my understanding is that with the calculation of the dollar amounts that they developed, included an expectation that payments would come for services rendered no matter who's delivering them. So part of that calculation includes the community-based organizations delivering the services. They're very specific in there about what monies are available for the respite. You know, there are lines so that things can't be duplicated. So if it's, you know, a home delivered meal is a challenge, as an example, because people are eligible to receive home delivered meals through other funding. So they're not going to pay for services that you would normally be providing, but as through other, say, ACL nutrition program funding. But definitely the expectation is that if they're referring you to deliver a service to their members, essentially, then they would be paid for. There is nothing in there that says that, as far as I know, there's nothing in there that says that community-based services and supports are not fundable through this capitated fee dollar amount that they're receiving. Marisa, do you have any thoughts on that one?
I'm sorry, I was trying to look for actually, so a lot of these questions, CMS is actually doing a webinar tomorrow.
Yep.
At 2 p.m., I believe, Eastern, focused on the guide model, which is a great place to get these. And we have a lot of questions in here that we are not going to be able to get to, and that are questions that are probably better suited for CMS. So I'm going to try to find a link to that webinar and post it in the chat. But if we can't get it, I would highly encourage you to go to the Innovation Center, cms.gov, and look for the Innovation Center to see if you can find that. But I'm going to try to do that while you continue to answer questions.
Okay.
Erin.
There's also a question here about occupational therapists being listed in the model. Again, that's a service that is being expected to be referred to. They would not be, if they could be billed with other codes for whatever the service is, you wouldn't double dip. You would either get paid by the participant for the services you're providing, and they would be paying you out of the capitated fee that they're receiving for each individual. Let's see.
And Erin, I just dropped the registration link for CMS webinar for tomorrow afternoon in the chat, and would highly encourage folks. They also have recordings of past webinars related to the guide model available, and I'm going to put the overall guide model. I know it's in your slides, Erin, but I'm going to put it in the chat too, in case people need it more quickly than the time it takes to get these posted.
There was a question here about the review of the guide applications, and is there a rubric? I asked them about that as well, and their statement was they were initially considering developing a rubric to assist applicants. They ultimately determined a rubric would not add any additional value beyond what is already contained in the RFA. They will evaluate applicants based on the completeness and thoroughness of their application question responses in relation to their ability to carry out the requirements necessary to participate either in the established or new program track for guide. Not all applicants are guaranteed participation in the model. CMS will also need to consider critical factors for ensuring a robust evaluation of the model, and may deny individual clinicians or any other individual or entity participation in the guide model based on the results of the program integrity review. And so that's me reading their response to my question on that, just to be clear. And the program integrity review, there's information on that in the RFA. And unfortunately, we are out of time. So we had to unfortunately leave a bunch of questions unanswered. But as Marisa said, you know, a great opportunity will be tomorrow to to hear from the CMMI folks themselves. We just want to thank you all for taking the time to be with us, and please don't hesitate to reach out if there's anything that we can do more to support you. Our abilities are limited, but we are certainly happy to try and answer questions when they arise, or at least guide you to people that can. Other than that, thank you. We will be posting the recording and the PowerPoint presentation on the National Alzheimer's and Dementia Resource Center website. It'll take us, you know, a week to get it up there. But again, thank you so much, and have a good afternoon.